Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
Today, we are really taking a different look at healthcare. Instead of us advising you on what you should be doing to improve your health, we are going to take a look at what we need to be doing to ensure our health. So we're hoping with this episode that both Sarah and I can learn some things too, but we want to try to understand the different types of health insurance. We want to really help you and help ourselves make better decisions during open enrollment or when looking at your individual plans from employers or from your state to really understand what is going to work best for you and go into some of the terms that you may see, like what's a cost-sharing plan, what's an HSA, what's a copay, and really talk about what these things are so that hopefully you can figure out the best plan for you when you're looking for insurance for yourself or for your family.
And we're really excited to have our guest today because despite working in healthcare, Kitty and I will never claim to be experts on this. So we had to pull in an expert, and today we have Whitney Kline, who is a personal benefits manager with HSA for America. She works with people every day trying to simplify this process of making decisions and educating them on the different options and picking out what fits their needs best. So Whitney, thank you for joining us. Can you give our listeners a little bit of background on who you are and how you got into this field?
Yeah, thanks for having me. I work with HSA for America, and we service all 50 states, but we're a relatively small team. We're a brokerage, so we work with traditional health insurance, what people are most familiar with, and then we also offer cost-sharing ministries, also known as health sharing. And so those are an insurance alternative, but the company really attracted me to it almost 4 years ago because the president of the company really looks to help people. It was very evident to me that he cared about people and wanted people to feel like they have options. And when you only know about traditional insurance, it does feel very limited. So I have enjoyed working with that company and being able to truly help people with out-of-the-box solutions with traditional insurance or these alternative options like health sharing.
I'll tell you what I did the other day, actually. So I just got on and looked at if I got on the state's health insurance site, like I was going to be involved in open enrollment next time, and I looked at what it says, what you need is a qualified health plan. What is that? Is that insurance? What is a qualified health plan?
Yeah, a qualified health plan is what meets the ACA mandate that used to be enforced. Some people feel like it still is enforced, but it's only enforced in certain states. It's no longer a mandate over the whole U.S. There's only state mandates now. But a qualified health plan, it meets the minimal essential value. So it has to have certain qualifications in the plan, and it can't exclude pre-existing conditions. So just things like that would make it a qualified health plan.
And when we are talking about health plans or health insurance, there's lots of words that we hear a lot. So can you go over some of these definitions of HMO, PPO, EPO, point of service? I just feel like people just start listing off a bunch of letters. How do you even go about trying to explain all these different big options?
Yeah. Here in Kentucky, we only really have HMOs on the individual market. You really only see PPOs and maybe some EPOs on employer plans. But when it's a PPO, of course, you can go in or out of network. So a lot of people will come to me looking for a PPO plan because they want that freedom. But unless they're offered employer coverage, it's not really an option right now this year in Kentucky. But HMO means that you have to stay in network. If you are wanting to see a doctor that is out of network, it's just not even an option unless you pay out of pocket. But with PPO, you can go out of network, but typically it's going to cost you more. So if you went in network, it'd be a $20 copay. If you go out of network, it would be like 30-50% coinsurance, and that leads to coinsurance.
We will come back to that for sure. I promise you. I promise you. Okay, so in-network is defined by your plan, and they basically have a list of in-network providers, and then out-of-network would be anyone that's not on your list of in-network people.
So HMO, you have very specific hospital systems, providers that you're allowed to use, and if you go out of that network, it's on you. PPO plan, which is only in Kentucky really seen with employers as an option, you're able to see in-network people for probably a cheaper price or out-of-network people for a little bit higher cost, but it's not full cash like an HMO plan would be. Okay, that's very helpful.
And just so I know, what is an EPO?
EPO is, you don't really see those a lot, and really the primary difference is that you do have a network, but you're not supposed to have a referral to see a specialist. But a lot of the times I run into individuals that they say, even though I'm not supposed to need a referral, traditional specialist doctors' offices will still want you to have one and still require it, even if it's not required by your health insurance.
That just makes it even more confusing.
It does, yeah. So when I looked on the state's website, you needed a qualified health plan, and then it said something about an APTC. Here's some other initials. So what's the APTC?
So it stands for Advanced Premium Tax Credit. It also has the name of a subsidy, or some people just call it a tax credit. And that's a type of financial aid. And actually a lot of people do qualify for it, because it is based off of your gross household income, and your household is based on your tax household. So if you're a couple that has 3 dependents on your taxes, that's your household. So if you have a 19-year-old child that has income, that's included on your gross household income. So your APTC is based off of your gross household income, your household size, and also your zip code, because it all depends on the federal poverty level.
Is it like a survey that you take with that, and then that says you get this much help with your insurance? Is that kind of how it works?
In Kentucky, they have a pre-screening tool on the Connect website that you can use that, but that's also something that I do with people. It's a good starting point to see if they qualify for any tax credit, because if they could save $1,000 off their monthly premiums with an advanced premium tax credit, then that's where we want to start, because that might be the most competitively priced option.
I've also seen the initials CSR, and I have to say, I have no clue what that means.
Yeah, that's another type of financial aid on the state-based exchange or just with traditional insurance that someone could qualify for. They could have APTC, that tax credit, in addition to a cost-sharing reduction. Cost-sharing reduction is a lower income level, but it's not Medicaid. So cost-sharing reduction can only be applied to a silver plan. So there's different metal tiers. A silver plan's the only one a cost-sharing reduction will work on. And if they qualify for that, it's almost impossible to beat it, because it reduces the deductible, it reduces the premium, the coinsurance, everything about the plan is reduced, sometimes even reduced all the way down to $0 deductible. It's just another type of financial aid.
So basically, you want to definitely see, do you qualify for APTC? Do you qualify for CSR? Because if you do, it's going to save you a lot in the end.
Yeah, and if they qualify for a really nice cost-sharing reduction, they don't want to just choose a bronze plan because it's cheap and it's a high deductible plan. If they could get this better plan with a lower deductible with a cost-sharing reduction.
Some of these things need to be taught in school. I'm just going to say that. This should be taught in school. You can't graduate high school unless you actually understand how to shop health insurance. I'm going to take it back there.
Yeah,
that and taxes.
Yes, that and taxes.
Yes, it should be a class. Health insurance and taxes.
Yes.
What you need to know just to get by. Part of the adulting series of high school. So since you brought that up, what you do is someone can come talk to you about all these options, right? And you navigate them through all the potential options and then help them figure out what each cost would be and what would be the best for what their family needs.
And I think that's important. I came from an employed standpoint to being self-employed. And when it came to understanding insurance at that change in my life, I had no idea. And I was like, is there someone out there that can help me? Because I don't know if many people realize that there are individuals who specialize this that can help talk you through this very confusing landscape.
Yeah, because you can have a connector through Connect help you to pick a plan, but they're not really insurance brokers. And you could also have someone directly from an insurance carrier like Anthem Blue Cross Blue Shield help you, but they can only sell you the best of what they offer at Anthem. So a broker is someone that offers all the carrier options. Like I offer all the options in Kentucky, so I'll help you to look through all of them with a consultative approach.
And how much would that cost someone to come talk to you about this?
The consultation's completely free. I just get paid through commissions.
So seems like a win-win.
Yes, I agree.
You want to know more about what your options are.
As we're talking about some more terminology, because I think this is helpful, so if we're talking about people who are having to get their own insurance and they don't really have these options from their employers, many people are stuck with HMO plans, and there's this terminology of in-network and out-of-network that we just talked about. But there always becomes that question, what do I do when I'm traveling? Because there's no one usually in network if you're in a different state.
It varies by health insurance carriers, but most health insurance plans that I've ever come across, they do have emergency travel coverage. That if it was life-threatening and you needed to go to the hospital, that it would be covered. But if you just need to see a specialist or there's some type of routine care you need while you're staying in New York for a month, for example, that would be out of pocket unless you have travel insurance if you're going to be gone for a long time with traditional insurance. It's not like that with health sharing.
Yes. We're going to get to that because I think that's something many people don't know about.
So before we go into some of these other things, can we talk about the other definitions that I found myself Googling a year or two ago when we had a change in insurance? I want to go through what's co-pays, what's co-insurance, what's out-of-pocket maximums, and deductibles. Can you take us through all of that? Maybe we'll start with what is a deductible?
So with a deductible, every insurance plan is going to have them. Some are high deductible. With a bronze plan, you're going to see the highest deductibles. And then silver plans, medium of the road, and gold plan is quote unquote the lowest deductible. So a deductible is what you pay before they start kicking into coinsurance. And it's probably better to just give an illustration that if you have a $5,000 deductible, and to go to the emergency room, it's out of pocket until your deductible is met. That means as soon as you walk into the emergency room, if you incur a $7,000 bill, that first $5,000 you're going to pay out of pocket because that's going to satisfy your deductible because you don't have a copay. And so once that deductible is met, then you usually will go into coinsurance for that emergency room visit. So with that $2,000 left of that $7,000 emergency room visit, if your plan has 30% coinsurance, so that's what you pay after that deductible, let's just use $1,000 instead. You would pay $300 of that $1,000 medical bill because that's 30% is your responsibility of coinsurance.
And then for the rest of the year, if you had to return to the ER, you've met your deductible. So then you would just have the coinsurance the next time.
You would, and that coinsurance would continue to chip away to satisfy your maximum out-of-pocket. And that one's kind of self-explanatory, that it's the maximum that's going to come out of your pocket for the year. So if your maximum out-of-pocket is $7,000, then that's the most you would ever pay in health expenses for the year on that plan.
And I always find that is going to the hospital and understanding that is easier. Now let's go to the outpatient world. Say someone is going to see their primary care doctor for an illness and they have a high deductible plan. What should they be expecting when they hit the door and they're going to that appointment and their doctor's ordering tests?
Yeah, so if you have a plan that has a copay for primary care, then that copay, maybe $30 copay, is only for the visit fee. So if you go to the primary care doctor and it's to investigate some symptoms you have, it's not a preventative care visit because preventative care is free. But if you were having some elective lab work or maybe the doctor even orders imaging, then those are going to be treated differently. It's not included in that copay. So for imaging, your plan might have, after the deductible, it's 30% coinsurance, like an emergency room visit. So you would pay for that imaging out of pocket until it meets your deductible.
I feel like many times patients, and because I would have them come back to me and confused, is if you have a really high deductible plan and you're going to the doctor and you're having workup and getting labs or whatnot, again, that copay is really only for our visit, but anything I may have ordered is just either you're paying it until you've met your deductible or it's still going to have the coinsurance cost. And I feel like people just don't know that. And so it can be very surprising, and that is not fun.
It's also surprising for people is, let's say you're going to your annual visit, which you think is going to be fully covered, but during that annual visit you say, also, I am having chest pain. And now you're going down the road of getting EKGs and doing workup for this chest pain. Even though you went there on your annual visit, this is actually a new problem. So that is not covered in your annual visit. That's a new problem, and then it's still going to be hit with these other fees.
And at traditional offices, a lot of times they end up coding it completely different. It doesn't even get coded as your preventative visit. It's coded as diagnostic. So then it's not even free for the patient. So it's a lot for them to understand. Like they shouldn't need to understand coding.
Yeah, but since you brought that up, screening versus diagnostic, I would see this also with some of our cancer screenings. So a mammogram or colonoscopy, if you're not having any symptoms, then that mammogram or that colonoscopy is just screening, and that should be covered with your insurance plan. But if you are having a breast lump and it's just time for your mammogram, or you're having tenderness with your breast, or you're having some sort of issue going on with your colon, you're having bleeding with your stool, then when you go in, that screening test gets coded as diagnostic. I saw people really be surprised with this, and they would think that it was going to be paid for, but then it gets coded as diagnostic because there's a problem, and then they're hit with that coinsurance fee, which can be a lot, with a colonoscopy in particular.
Labs the same way. Mm-hmm. It's not easy to understand. I was like, why have we made such a complicated world? This should be easy and clear and concise, but it is one of the most confusing process because even year to year, your plan changes, and what happened last year versus the next year, it could look completely different. And it's hard to just keep up in general.
And so if you have a family, so let's say you've got 2 kids and a husband and wife, and the husband goes to the ER, and we already talked about what happened there. And so he's paid a certain amount, but now one of the kids, let's say, needs to go to the ER. They fell and broke their arm the next month. They've got their own set, right, of what they have to meet for their deductible, even though they're under the same plan. Can you make sure we all understand how that works?
So there's an individual deductible, and then there's a family deductible. So if you had a family on a plan and the individual deductible is $3,000, but the family deductible is $6,000, that first family member might have already satisfied their $3,000 deductible and crossed over into maximum out-of-pocket coinsurance territory. But the family deductible would still need to be met if something happened to another family member. So if the son had an accident and satisfied the $6,000 family deductible, then if something happened to another family member, then they wouldn't have to pay an individual deductible because that family of $6,000 deductible is already met. So I guess it's like a safety net, but for a family, it's essentially like you have 2 deductibles, the individual deductible times 2 on most plans.
And when it comes to picking plans, and you're looking at all these options, and it's really hard to be like, which one should I do? Because there's advantages of high deductible plans, but there's also advantages of those lower deductible plans as well. What are some things people should be thinking about when they're making that decision other than just the cost of the plan? because that's usually the easiest to look at, right? But then there's all these other decisions. What are things people should be asking themselves before they decide?
And the cost you call the monthly premium, right? So the monthly premium is what you're paying every month just to have the plan. And then the co-pays, the coinsurance, the deductibles, those are all the things you're paying on top of what you're just paying monthly to have the plan.
Yeah. And so some of the questions that I ask people in the consultation that it would be good for them to already be thinking themselves is, what does a general year look like for you? Do you typically have certain labs ran every year that are elective? Or do you know that you're going to have frequent imaging? Maybe you already have a condition that you have to have an MRI every 2 years or something to that effect, so that we can not only just look at the cost, but try to anticipate the annual expense of what the year is going to look like for you as an individual. And for each family member, having a list of your doctors and medications is important to make sure that especially here in Kentucky, it's an HMO dominant area. So just making sure that those doctors are in network, and the medications too. The medications are a big one. Sometimes we have to pull in some additional resources just to make sure those are covered.
And that's something that can change year to year even. So sometimes you have to reassess just the next year because insurance has decided to change their requirements or their pharmacy recommendations or what they have on their plan. It's just complicated in that sense. Sometimes there's an option from an employer of doing these high deductible plans and pairing it with health savings account. How does that work as an option for someone?
So a lot of people do like to have HSAs. It's not something that you can go out and just get an HSA. You have to be enrolled into an HSA-eligible health plan. A lot of people don't realize that. Sometimes they were in an HSA-eligible plan, opened a HSA, and now they're in a different plan, and they've been contributing to it for all these years. So if they were ever to be audited by the IRS, they would owe back all of those contributions.
Stop. So if you've been in a high deductible HSA plan and then you change to some sort of preventive plan or something that doesn't have an HSA, what happens to everything you put in your HSA?
So that's still your savings account. It's like someone can't come in and take your savings account, just your basic savings account from you. But the HSA has special tax treatment. It's one of the few savings accounts that has triple tax benefits. So you have to be enrolled in an HSA eligible plan to make the contributions each year. So you can still use the funds in it if you're not in an HSA eligible plan anymore, because those are your funds. It'll roll over year after year, follow you. It's just the IRS only allows you to contribute the contribution when you're in a plan that is eligible for it.
Okay, so if you switch to a plan that wasn't, you could keep that money stable, let's say, and either take things out or do nothing with it, but you couldn't add to it unless you got back into
Exactly.
an HSA plan. Okay.
And what kind of things can an HSA help with when it comes to health coverage?
There's all kinds of lists out there of HSA eligible expenses. Anything your doctor writes you a note for, you can use HSA funds for it. That's one of the biggest questions we get is, can I use HSA funds to pay for my supplements? And if you have a doctor's note that says you need it, then yes. But if you don't have a doctor's note for it, no. But any other medical expense like rubbing alcohol from the store, a lot of times it'll be advertised at grocery stores if something's HSA eligible, or even just buying medical equipment is HSA eligible. If you have an HSA eligible plan, I think they're typically a better fit for a healthy individual simply because they're a high deductible plan and you don't see copays on HSA eligible plans. So if they go to a specialist frequently throughout the year, they could use HSA funds for it, and it would be tax deductible. It wouldn't be taxed as a purchase, but it would be out of pocket every visit. So the whole visit, there's no copays.
So that might be right. Depending on who you're seeing, it might be a visit that's $180. It might be a visit that's $400. If you do have one of those plans, really talking with the office up front and making sure you understand what your cost is going to be.
Because I could definitely see someone who's healthy, maybe they are just seeing a dermatologist once a year or whatnot, where that financially makes sense. So I'm just paying for this one-time visit with this specialist, and I'll just use my money for my HSA. Yeah.
Yeah. And I'm not a tax specialist. I can't give tax advice, but with the HSA, if you do have the circumstances that it makes sense for your family, then that's something I usually educate my clients about too, is just how that contribution, which is different for an individual than it is for a family, changes year after year. That's all tax deductible to you. And if you choose a HSA bank that has investment options, you can invest all that money. That's a lot of money to just be sitting there not working for you. And then when you use it for medical expenses, it's not taxed as a purchase. So there's a lot of tax savings there that if you are healthy, you don't have a lot of medical expenses, it can actually make up for a lot of the premium expense and possibly even come out positive at the end of the year.
So it sounds like you should also talk to your accountant as well. Make sure you're optimizing this money. Great advice. And there's also, again, all these letters. Literally, my brain wants to explode. HRA. What is that one?
Typically, that's not something that comes up for individuals. It's more for business owners that are looking to offer that to their employees because it's a health reimbursement arrangement. It's designed to help employees. It's like an allowance that's not taxed to the employee that they can use to pay for healthcare premiums.
And speaking of those letters, and while we're on this, can you also talk about what an FSA is?
That was most commonly confused as an HSA. The FSA is a flexible spending account. It's not something that I would help someone to set up. It's an employer benefit that if you have an employer that offers an FSA, it's like an allowance. They give you an allowance for the year, and if you don't use it, you lose it at the end of the year. So it's not like an HSA that rolls over year after year. And the HSA, you carry that with you, even if the employer funded it for you over the years. The FSA is just used for medical expenses, but it is a little bit more flexible, hence the name. Some people can use it to pay for even stuff like childcare. So it's a little bit more flexible and doesn't stick around at the end of the year.
Yeah, that's one thing I had at one point in my life with one of my jobs, and I really didn't understand what those dollars were for, and I wasted them multiple times until I finally realized, yeah, because they do disappear at the end of the year. So if you're somebody and you have an FSA and you do not spend a lot of money on your health care, you're healthy and you don't have to spend a lot on it, you should definitely look into what that covers, because it can even cover some things like sunscreen, eye drops, those types of things, maybe even some dental things that you need. So if you have a plan from your employer that has FSA dollars, don't let them go to waste.
Now we want to turn into literally a topic that I knew zero about as a doctor.
I still know zero about it.
So I at least had heard many of these things that we've talked about before. I over time have learned about them and understand them better. But this is one that I feel like many people don't even know exists. Whitney, can you explain what are cost sharing plans?
Yeah, they're becoming more and more popular, I think, just out of necessity. They're an insurance alternative. The language for cost sharing is completely different. You can't refer to it as a plan, cannot refer to it as insurance. There are no terms like deductible, coinsurance, copays. And it's very different because you can't learn about one cost sharing option and feel like you know about all of them because they are so different from one another. I offer about 10 different options. It took me so much longer to learn about those than it did health insurance when I was getting started. But in general, just as a broad explanation of them, a cost-sharing ministry or health-sharing membership is what they refer to them as, is an insurance alternative. So it's not insurance, but it serves the same purpose, but it's not a fit for everyone. So it's not a qualified health plan that anyone and everyone can be a part of it, and it's going to serve their needs. So with cost sharing, it's generally a fit for someone that's a healthy individual or a healthy family, that they don't have a lot of medical expenses throughout the year. And across the board, all cost sharing options have waiting periods and limitations for pre-existing conditions. I generally say if you have a health condition that there's a high probability of hospitalization in the first year, that I would not recommend it for you. If you have a heart condition, it's not worth the risk. But if you're a healthy individual and you don't use the doctor very often, or if you have a direct primary care membership, That's one of the best pairings with it because you get the best of both worlds.
And we have a whole show about that too.
And so with cost sharing, you do have an amount that you pay before sharing begins. So if something is shareable, that means the health share shares towards it. If it's unshareable, that means it's your responsibility, but you do have a monthly contribution that you make, a monthly payment to be a part of the health sharing community. And when medical things do come up, if it's not a pre-existing condition, it's shareable within that health shares guidelines, then they share towards the cost after you've shared your amount that you're responsible for. One of our most popular options has an option that the amount you're responsible for is $1,000, but that's per medical incident up to 3 incidents. So that's not a lot of expense that you would have, especially if you only have one accident because you're a healthy person and just have a mountain biking accident, that you only pay $1,000 when you go to the emergency room, and then everything else is shareable for that event.
And when you say shareable, that they're not covering that cost beyond that 1,000? Just make sure I understand that.
Yeah, so when something's shareable, it means the health share shares towards it.
Okay.
And how much do they share? Like, are you sharing 50% and they're sharing 50%? Or what does that mean?
So you don't have any of the percentages with health sharing. It's just you owe that flat $1,000 for this particular membership. It's not across the board. And then everything after that $1,000 that you've paid for, your unshareable amount, everything would be shared by the health share after that for that mountain biking accident.
So what about you have an unknown rash that comes up, something new? So you have this unknown rash and you end up needing to see the dermatologist 5 or 6 times that year. How does that work?
It's hard to get into it without explaining one specific health share option because they're so different.
Maybe let's go through 2 different ones, like how it would maybe work. So for this one with that $1,000 event, how would it work in that plan?
Okay, so with this particular option that has the $1,000, it's called the IUA. The IUA is your initial unshareable amount. If you had an event like a random rash, all of it has to be related to the same medical need for it to apply to the same IUA since it's per medical incident, and you would only pay up to 3 of those IUAs a year. So let's say you go to the specialist several times throughout the year for that rash. All of those expenses get applied to the same IUA. If you had 2 separate, unrelated visits to a specialist, like one was about a rash, another one was about a broken toe, then those would be 2 separate IUAs because they're not related.
So you'd pay up to $1,000 on the rash part over time throughout that year. But once you got to $1,000, if there was any more cost, then that would go to sharing. And then you'd pay for the broken toe to see the podiatrist or whoever for a few times. And hopefully that wouldn't get you to $1,000, but it might. And you'd pay on that one too.
Yeah.
And then what happens when you get to if there's only 3 covered, what happens when you get to the 4th?
So after you've paid 3 IUAs, you owe nothing more.
Okay. So if you just have a bad year, and say you do have a bad year, because as Kitty and I know, sometimes one thing leads to another that leads to another. And depending on what happens to an individual that they may not have had before, they have multiple conditions that have developed. The next year, are they usually able to start over again? Or is that a time where they need to start looking for a different type plan?
It varies from health shares.
Okay.
Because some of them have, instead of a per medical incident, some health shares do have, you just have one flat amount. It's not usually $1,000. It's more like $2,500, but that's all you pay for the whole year. So it varies from health share to health share. With the IUA, if you have an IUA open for a medical event, say it's something that rash turned into cancer. That cancer might go on for 3 years. As long as you have medical expenses coming in for it and there's not a gap of 6 months with no medical bills, that IUA is going to stay open. Unlike a deductible, where you'd have to pay a new deductible because it's a new year, the IUA is going to continue rolling over as long as there's medical expenses coming in.
Interesting. So then what's the downside of one of these plans?
I know, that's what we get most often. It sounds too good to be true. But the downside is just if you're not a fit for it. Maybe you had cancer a year ago. There's a look-back period for pre-existing conditions, which is different for every health share. You never see less than a 2-year look-back. Some of them look back even further than that. And all of those pre-existing conditions show up in your medical records. If you have a pre-existing condition like cancer from the past 2 years, then this wouldn't be a fit for you, because if that cancer resurfaces while you're in your waiting period for pre-existing conditions, it wouldn't be shareable.
Or if you have a bunch of pre-existing conditions, the plan might just say, no, you can't join us, or
They're just not going to
pay for
cover any of those old things.
They just won't share towards it because they ask in enrollment if you have any pre-existing conditions from XYZ time period of a look back. And even if you don't disclose that you have that condition, if you go in for treatment, it's going to be coded in such a way that it's going to show it was a visit on something that was already existing. But with another disqualifier that I usually will take a look at is their medications. Some of these health shares will have a small generic RX plan built into it, but generally it's only really helpful for generic medications. If you have some expensive name brand prescriptions, if you're not able to get that at a better price through your DPC or through costplusdrugs.com or another source that has good quality priced medications, then it would just be not a fit for them, because most of the time manufacturer discount cards that make the drug affordable, they require you to have commercial insurance, which is a qualified health plan, which is Unconnect.
Oh, that's helpful.
Yeah.
And so if you're on one of these plans, and let's say, you went for that initial rash, it ended up being cancer, we're going into the next year. Since that condition happened while you were already with that cost-sharing plan, they're going to continue to cover it, right? Or do you get into a territory where they're like, oh, we're not going to keep you in the plan?
So if it's not a pre-existing condition, they will continue to share towards it. It's hard to say as a blanket statement. It's always good to check the member guidelines, that if something comes up, to just make sure that there is not like a cap for a certain condition, which that's another good point, that tobacco users. Some of them will accept tobacco users, but not all of them will. You usually have a surcharge per month. If you're a tobacco user, maybe $50 extra a month. And then there are limitations, like they'll only share towards lung cancer if you're a tobacco user to a certain amount. So those are all things to just be aware too, that we go over in our consultation with individuals, that just trying to make sure that they're a good fit for that option.
Is there any risk of, let's say you have a bad accident, you're in the hospital for 3 months, and you have this huge bill? Is there any chance that the health share runs out of money and then you're on the hook or something like that?
So after the pandemic, I know that there was one health share in particular. It's not one that we offered. We tried to vet them and just keep a pulse on them, because any business, a company can go through hardships. But there will be red flags if a company is not financially stable, like they're taking a long time to pay their medical needs, or they are trying to get out of paying medical things that are shareable according to their guidelines. So we try to keep a pulse on all the ones that we choose to offer at HSA for America. But there was one in particular that they didn't go completely under, but they were having trouble paying their medical needs after the pandemic. And that was just not being structured in a way that they were able to survive the burden of a pandemic. But that also happened to some health insurance companies that we offered. They went bankrupt during the pandemic and went out of business.
Yeah, like in my mind, I'd think if that happened to a health insurance company, the hospital wouldn't come after you, even if the health insurance company paid. But
No, they do.
I do want to go back to prescriptions for full understanding of this. If you have a new diagnosis, let's say you have a new diagnosis of an autoimmune condition that occurs when you have one of these health shares, and you have an expensive medicine that there's not a generic form, does that cost, that continuous cost that's now going to happen, does that get covered after your, say, $1,000 if that's what you have, or is medicines always their own bucket?
Medicines are always their own bucket. They don't share towards maintenance medications. If you have curative medications, those would be shareable because it's part of that medical need as a curative medication. So an example of a curative medication would be your chemo pill for curing cancer or fighting cancer.
Okay, but not something that is a chronic maintenance therapy because this condition's never going away.
Yeah.
Okay.
Or let's talk about the medicine that is hot in the press at the moment, which has various insurance coverages. What about GLP-1s for obesity? Is that something that a health share would help you with?
They don't help towards those things, so that a lot of times is one of the ones I run into that's a disqualifier. I'm coming across Mounjaro a lot, and Mounjaro will not give their discount card to patients that don't have commercial insurance. So that one is one that just, they wouldn't be a fit.
That it's helpful to distinguish. We've mentioned it. I quickly said, hey, we had a show about that. But how do these match up well with a direct primary care practice and helps people get optimal coverage doing that combination?
Yeah, maybe they are a relatively healthy person, that they don't have a lot of pre-existing conditions. So they would like a health share because it's so much more affordable monthly. Maybe they don't have any tax credit through the marketplace, or it's very minimal, more of a headache than it's worth. Then a health share would be a great fit for them. But this option that we've talked about a little bit with the IUA, if you have a one and done visit, like a sick visit that you want to go in person, or you have an autoimmune disorder that you would like to see a specialist every 3 months and do some elective labs, those things would end up being unshareable because it would never have the potential to meet your IUA. If you just have the flu and you go into primary care, that's not going to cost you $1,000. Or if you go to a specialist every 3 months, it might just be $75 here and there. It just trickles in. But with a DPC, they would have unlimited access to that direct primary care, and there's all kinds of other benefits that come with it. And even for me personally, I wanted a certain elective lab panel done, and my primary care office that I used to see wouldn't even let me run those labs without putting me through 3 different tests first. With the direct primary care, they have such better pricing on labs for cash pay patients, since that's mainly who they cater to. And so it's the same with these health shares, that health sharing is not insurance, so you technically are a cash pay patient. So they just pick up where the other one leaves off. It's like they wrap around each other very nicely. And then if they need to go out of the DPC office for mammograms, colonoscopies, then a lot of these health shares, they share towards those larger preventative ticket items. So that's nice too, that it also picks up where the DPC leaves off.
Yeah. So most of the preventive screenings, mammograms, would be fully covered with a health share, or?
It depends on which health share they want. Some can opt for one that doesn't have those options, and it's going to be cheaper. But the one that has the IUA, that's our most popular options, especially for self-employed or business owners, because it's HSA eligible. And it has those preventative items that are included, doesn't cost them anything at all. They don't have to pay an IUA for it, and it's available from day one. So,
can you give me an idea of what is the monthly premium?
That's exactly where I was going. Let's say there's Sally.
What's the difference?
Let's say there's Sally, who is a 45-year-old female who is has no medicines, no medical conditions, and she is just curious about wanting to switch over. What would her monthly costs look like for that? And then we could talk about the average cost of direct primary care. What are we talking about monthly?
And by the way, that's episode 29 if you want to go back and hear more about what a direct primary care office is like.
So with someone in these prices are age banded. So we have different options based on, that's another part of the consultation, is just based on how old they are, how many are in their family, which of the options that are similar to one another, which one's going to be better priced for them. So for the 1,000 IUA, if they're in their 40s and it's just one person, then it would be $336.
Wow.
Compared to, let's say, like a silver state plan, what on average would that be about?
Oh, goodness. It's going to be different for every zip code in Kentucky, but the pricing is very competitive, especially for those like 40 and older, because the pricing on Connect is going to be more expensive for those that are older. So if they're in their 40s, a plan on the marketplace, it would be around like $600. So it's almost half.
Oh.
Okay.
And then if you paired that with a direct primary care, those, depending, a lot of those are age variants, and that can be $75 up to $125 a month as well. But overall, that combo is much less than something on the marketplace.
Yeah.
And do you recommend these for families too? Like if it's a relatively healthy family?
Oh, yeah. We have all kinds of families that generally, if you have two parents that are very healthy, the kids are too. And a lot of families too that they want to use direct primary care or they seek out holistic medicine. Because you're cash pay, this option is more open to those types of treatment. As long as it's medically necessary, that's the only thing that they're interested in, is just making sure it's not just elective treatments and tests.
Cosmetic or something. Yes, yeah.
Yeah, like they're not going to share towards cosmetic stuff. Then yeah, it's a fit for a family too. Typically, if they're like a family of 5 and they have 3 rowdy little boys that are likely going to break something and injure themselves at football, that even we could pair it with an accident rider, which is insurance, and the accident rider will cover anything that falls below the IUA, as many accidents are had throughout the year.
Something else I didn't know that existed.
It's weird because I think like I feel leery. I don't know if that's I feel like, ooh, is this okay? Because I've just always been in this world of traditional medicine, traditional health insurance, that things outside the box make me go, is this safe for somebody? Is this okay? Do you feel that way too?
I know. You have to think we were employed for so long that you didn't even explore these options because it wasn't necessary. But once you are not and you're having to look at all these options, it's opened my eyes significantly. Also opened my eyes and why we wanted to do this show, because there should be a whole class on this because it's so complicated and people are having to make these decisions and don't really even understand how it works.
Do you know, Whitney, are more people opting for alternative options like this than they used to, or is it a consistent number of people that do it every year?
Yes, and I'm licensed in 5 states. And so I've had a lot of people from California, Colorado, Florida, the larger states. It's been a lot of people from those states for the entire time I've worked at this company in the past 4 years. But I'm noticing more and more coming in from Kentucky, because I noticed that in the beginning. I was like, I hardly ever get any leads from Kentucky that are interested in health sharing. But I think it's just becoming more and more just known about, and ideally people are getting educated before they choose these, because most of the people that are upset and had a bad experience with health sharing, a lot of them expected it to operate like health insurance, and they didn't like the extra responsibility of being cash pay, or they thought it was going to share towards this pre-existing condition because they didn't do their research, and they ended up in a hairy situation. But if you know what you have and you know how to use it, I've been on one of these health shares for 5 years now, and we've had to use it only once, thank God, but it was a seamless process. I've been on 2 different health shares myself and had good experiences with both of them.
So this would be a time, if you are someone that's frustrated with what your insurance options are or what the bills you're having to pay are, really be worth talking to someone knowledgeable like you about a health share before you jump in to see if you are a good candidate for it.
Yeah, I like to narrow it down to 2 or 3 options, and it can be a traditional option and a health sharing option, just so they still have choices. But instead of choosing from 50 options, they're choosing from 3. But it's great, and we talked a little bit about international travel. Some people are even missionaries in other countries, and health sharing works for them because it's cash pay, and they can receive care outside of the U.S.
Oh, that's a great point. Are there other strategies that you tell people to help reduce health insurance costs, or just trying to get the most out of what they have? Because, again, I feel like most people struggle even understanding their coverage.
I think one example comes to mind that I had a couple, and they were just opposite ends of the spectrum. One spouse needed a lot of care. There was going to be a lot of expenses that year. He would have benefited from a low deductible plan because annually the expense for him was going to be better. But for her, she was very healthy. No medications, nothing. Sometimes people don't even realize that they feel like they got to stick together.
I've always felt that way.
For sure. And that's usually because when you're employed, that's how the plans are sold. But if you're out on your own, you don't have to do that.
And it doesn't always make sense, but we investigate all of those options. Like if that's the situation they're in, that it ended up being cheaper for that family to split them up. She was on a high deductible plan with an accident and critical illness rider, so that if something happens, it's not going to break the bank with a $9,000 maximum out of pocket. because they have that rider. But he was on a lower deductible plan, and it helped them financially that year. And she didn't have to worry about, everyone always wants the high deductible plan because of the premium, but they're always nervous about that deductible and that maximum out of pocket, and reasonably so.
And I know that those numbers are going up for a lot of employer options this year. Those numbers, those deductibles and out-of-pocket max are going up for most people. So make sure you do take a look, because it may be very different than what it was last year even.
Yeah, and even in the upcoming years, it's only going up. And so every year, reassessing what works best for you and your family, because many times we just don't even think about the other options. And sometimes as things change in your life, other options are better.
So just boiling it down and making it overly simplified, which I understand I am overly simplifying this. If you're someone that has a lot of chronic conditions, you see a lot of doctors, you have a lot of care throughout the year, you're probably better off with a low deductible plan, even though it's going to be a higher monthly premium. If you use a lot of healthcare services, that's probably a better option. If you're not someone that uses a lot of healthcare services, then looking at a high deductible plan with an HSA or looking at a cost-sharing plan might be a better option for you, because you're going to have a lower monthly premium. And then I guess just thinking about deciding between a high deductible HSA versus a cost-sharing HSA would be looking, what's that monthly premium? Who are the doctors you want to see? If you'd rather see someone that's a DPC doctor, then maybe the cost-sharing plan would be better. Or if you're wanting to see someone that's out of network, maybe that would be better, versus the high deductible plan might be better if you're definitely just seeing the people you know that are in network and you know what your cost is going to be.
Yeah, I would agree with that. And I have had plenty of people that have come from a DPC that they are looking for their best option, but they have pre-existing conditions. And maybe that is just being on a high deductible HSA traditional insurance plan that they get some tax credit on. But if I can just help them to lower that monthly cost so that they continue seeing the DPC, because that's usually what their goal is. They want the superior level of care that they receive at their DPC. So just helping them to make room for that and educating people on the HSA. That's the biggest thing that I feel so disappointed in, is there's so many people that have HSAs and they don't realize what they're missing out on by not funding it.
And also, I used to just think DPCs were primary care, but there's a lot of specialists having DPC clinic now too. So even if you have a rheumatologic disease or an endocrine disease, there are DPC specialists out there as well.
And sometimes they don't use the same terminology, so it's hard to find, because in the primary care world, direct primary care doctors are always throwing out DPC, but some of these specialists is just, if you get on their websites, you'll see that they offer a monthly fee to be a patient. And so they're set up just like the direct primary care offices, but they're a cash-based practice. That's how it's easier to recognize it, is looking that way, versus a concierge service specialist, which would be billing your insurance plus paying an extra fee. So you can figure that out just by paying attention to how the pricing is set up and seeing if they accept insurance or not.
And so, Whitney, you mentioned people not funding their HSA wisely as being a common mistake that you see. Are there any other big common mistakes or misconceptions people have frequently?
With the HSA, oftentimes people don't realize that there is a maximum contribution they can make. And they also don't realize that once you put that money into the HSA, you can't take it out for non-medical expenses without paying a small penalty and the taxes on it. But once
you can take it out for medical expenses anytime, right?
Yeah.
But if you don't want to take it out for a medical expense and you're just using that as potential future retirement funding, you have to wait.
So once you turn 65, you can no longer make HSA contributions. But at 65, you can use HSA funds to pay for your Medicare premiums tax-free. Whereas if you're younger than 65, HSA funds can pay for your co-pays, deductibles, but never your premiums. That's another misconception. I see people will be using HSA funds to pay for premiums, but it makes a great retirement fund because you can pay for those Medicare premiums tax-free after 65. You can take it out if needed for non-medical expenses after 65 and not pay taxes on it, and there's no penalty. So it's not like it's stuck in there forever. But I just tell people don't put all your life savings in your HSA before you turn 65.
That's helpful information to know.
Okay, so I am going to do my very best to try to summarize what you said. I will say I did sleep well last night, so we know that's going to help my learning today from Whitney.
We just came off a series about sleep, so your recall should be ready to go.
So if you are someone looking for insurance, you want to look for a qualified health plan, which may be an HMO, particularly if you're in Kentucky, probably only an HMO, or a PPO, and that may vary if you're getting a plan through your employer or if you're going to get it through the exchange. And if you are getting it through the exchange or through Connect, you want to make sure that you look to see if you qualify for the financial aid with the APTC tax credit or with the CSR, and those could be very beneficial for you in picking a plan if you do qualify for those. And then if you're not looking at that, if you're looking at something through your employer, you want to think about, do you want to go with a high deductible plan that potentially has an HSA? Or if you have a lot of medical costs, would you rather go with a low deductible plan? And remember, if you do go with one of those and you get those FSA dollars with that, make sure you use them because they go away at the end of the year. And then just looking at copay, that's going to be a set fee for what you pay for different doctors that you may see. The coinsurance is a percentage of your medical bill that you're going to pay, and that usually starts after you've met your deductible, which will be a certain amount, and then you pay that coinsurance percentage until you hit your out-of-pocket max. But you may have a specific deductible for each person in the family if you have a family plan, so you have to hit maybe several individual deductibles until you've hit your entire family's out-of-pocket max for the year. The other option that you may want to think about is these cost-sharing plans, which you've taught me so much about today, and these are not technically insurance. They're an insurance alternative. They're going to be better for a healthy individual that does not have a recent pre-existing condition. And then you want to think about your medications if you're considering this as well, because if you're using specific name brand medicines, it may not be a good option for you. But if you're someone that takes generic meds, this might be a really good option for you, especially if you're pairing it with a direct primary care office.
Whitney, thank you so much. We would love for you to tell our listeners how could they reach out to you. I know we'll link stuff in our show notes, but how could they connect with you if they are wanting to set up a consultation for you to go over some of this information individually?
Yeah, so they can reach out to me by texting me or emailing me, and I can send them my calendar link. They can reach me at 720-741-1566. And my email is Whitney Kline, WHITNEY, KLINE, at HSA, like a health savings account, FORAmerica.com. Or if they want to do the easy route, they can find me on Google by searching Whitney Kline here in Kentucky.
We'll put all those links as well so you guys can find Whitney. And it sounds like if you are not in Kentucky, there are people you work with that could help them out as well.
We can help people in all states. I'm personally licensed in Alabama, Florida, Missouri, Minnesota, and Kentucky, of course, and South Carolina recently.
Congrats.
Hopefully you all enjoyed this episode. If you learned a lot about insurance or you have friends or family that are trying to understand or pick a plan that better suited for them, please share this episode so they can learn with us as well, because we know this is a very confusing topic. So hopefully you all found that helpful. Don't forget to leave us a review and rate our show. We just want to say thank you for listening and giving us feedback on ideas for shows. If you have any other topics that you all want to hear about, please don't forget to send us a text or email us at contact@thestartinggatepodcast.com.
We'll see you next time.